Greetings dear viewers. In this video, I would like to explain about the Varicella Zoster virus and its infections. Varicella causes chickenpox in human and Zoster virus causes shingles in adults. I am Dr. M. Manigandan from the Department of Microbiology, Sacred Heart College, Tirupattur. History of the Varicella Zoster virus. In 1875, Rudolf Steiner demonstrated that chickenpox was caused by an infectious agent by inoculating volunteers with the vesicular fluid from a patient with acute varicella. In 1954, Thomas Weller used cell culture to isolate varicella zoster virus from vesicular fluid of patients with varicella or zoster infection. A live attenuated varicella vaccine was developed in Japan in the 1970s. The vaccine virus was developed from virus isolated by Michiaki Takahashi from vesicular fluid from an healthy child with varicella disease. Incubation period of the varicella zoster virus infection is around 14 to 16 days, which may extend up to 21 days. Prolonged incubation period may lead to post-exposure prophylaxis with varicella-specific immunoglobulin. Introduction. Varicella zoster virus causes chickenpox and upon recurrence causes herpes zoster or shingles in adults. The varicella zoster virus belongs to an alpha herpes virus family and it shares many characters with herpes simplex virus. At first, its ability to establish latent infection of neuron and recurrent disease. And second, the importance of cell-mediated immunity in controlling and preventing serious disease. And finally, the characteristics blisters-like lesions filled with fluid causes itchy rashes. The chickenpox is highly contagious to people who have not vaccinated. Unlike herpes simplex virus, varicella zoster virus spreads predominantly by the respiratory route and after local replication of the virus in the respiratory tract by viremia, it forms skin lesions over the entire body and the rashes causes intense itching leading to bacterial superinfection and permanent scarring. The structure and replication of the varicella zoster virus. The varicella zoster virus virions are spherical in nature with 180 to 200 nanometer in diameter. The virus is surrounded by a lipid envelope which encloses the icosahedral form of nuclear capsid. The genetic material of varicella zoster virus is a double-stranded linear form of DNA with approximately 125,000 bases. The varicella zoster virus has the smallest genome of the human herpes virus family and it replicates in the similar manner compared to the other human herpes viruses, but it replicates in a slower manner and replicates in few types of cells. The varicella zoster virus establishes latency in the neurons, which is extremely communicable. Pathogenesis. The varicella zoster virus is generally acquired by inhalation and primary infection begins in the tonsils and mucosa of the respiratory tract. The virus then progresses via the bloodstream and lymphatic system to the cells of the reticuloendothelial system. A secondary viremia occurs after 11 to 13 days and spreads the virus throughout the body and to the skin. The virus infects T cells and these cells can home to the skin and transfer virus to the skin epithelial cells. The virus overcomes inhibition by interferon alpha and vesicles are produced in the skin. The infections in the skin are dermal vesiculopustular lesions along with the fever and systematic symptoms can occur. Virus replication in the lung is a major source of contagion. The virus becomes latent in the dorsal root or cranial nerve ganglia after the primary infection. The virus can be reactivated in older adults when immunity reduces or in patients with the impaired cellular immunity. On reactivation, the virus replicates and is released along the entire neural pathway to infect the skin, which causes a vesicular rash along the entire dermatome. This is known as herpes zoster or shingles. This damage to the neuron and which may result in post-herpetic neuralgia. Gets transmitted from an infected person to a healthy person through the droplets, and the initial replication takes place in the tonsils and mucosa of the respiratory tract. The virus then progresses via the bloodstream and lymphatic system to the cells of reticuloendothelial system through the secondary viremia, which occurs after 11 to 13 days and spreads the virus throughout the body and to the skin. The virus which is infects the T cells, and the T cells brings the viral particles to the skin and it acquires the skin epithelial cells, and the virus overcomes inhibition by the interferon alpha, and due to this the vesicles are produced in the skin, and the vesicles are identified in macules, papules, vesicles, pustules, and crusts. The virus remains cell associated and is transmitted on cell to cell interaction, and the latency of virus has been found in neuron. Clinical syndromes. Varicella or chickenpox is one of the five classical childhood infection along with rubella, roseola, fifth disease, and measles. The characteristic maculopapular lesions were acquired after 14 days of incubation. Within hours, each maculopapular lesion forms a thin-walled vesicle on an erythematous base, which looks like a dewdrop on a rose petal, which measures approximately 2 to 4 mm in diameter. This vesicle is a hallmark of varicella. Within 12 hours, the vesicle becomes pustular and begins to crust, after which scab lesions appear. Successive crops of lesions appear for 3 to 5 days, and at any time, all stages of skin lesions can be observed. The rash spreads across the entire body, but it is more prevalent on the trunk region and head region. Its presence on the scalp region distinguishes it from many other rashes. The lesions itchy and causes scratching, which may lead to be bacterial superinfection and scarring. Lesions on the mucous membrane typically occur in the mouth, conjunctiva, and vagina. Primary infections is usually more severe in adults than in children. Interstitial pneumonia may occur in 20 to 30% of adults and may be fatal. And the herpes zoster, the latent recurrent infection in the patient's life, leads to severe pain in the area innervated by the nerve, usually precedes the appearance of a chickenpox-like lesions. The rash is limited to dermatome and resembles varicella. A chronic pain syndrome called post-herpetic neuralgia persists for months to years, occurs as many as 30% of patients in whom herpes zoster develops. Laboratory diagnosis of varicella zoster virus infection. The cytopathic effect in varicella zoster virus infected cells are similar to those seen in herpes simplex virus infected cells, and it also includes cowdry type A intranuclear inclusions and syncytia formation. These cells may be seen in the skin lesions, respiratory specimens, or organ biopsy specimens. Syncytia may also be seen in Chang smear of scrapings from vesical base. Direct fluorescent antibody to membrane antigen, that is FAMA test, can also be used to examine skin lesion scrapings or biopsy specimens. Antigen and genome detection are sensitive means of diagnosing varicella zoster infection. PCR is especially useful for systematic and neuronal diseases. Serological tests that detect antibodies against varicella zoster virus are used to screen populations for immunity against varicella zoster virus. However, antibody levels are normally low and which can be identified with the ELISA test. A significant increase in antibody level can be detected in people experiencing herpes zoster infection. Treatment. Treatment may be appropriate for adults and immunocompromised patients with varicella infections and also for shingles infection. But no treatment is usually necessary for children with varicella. Acyclovir, famciclovir, and valciclovir have been approved for the treatment of varicella infections. There is no good treatment for the varicella infection, but analgesics and other painkillers, topical anesthetics, or capsaicin cream may provide some relief from the post-herpetic neuralgia that follows zoster. As with other respiratory viruses, it is difficult to limit the transmission of varicella infection because varicella infection in children is generally mild and induces lifelong immunity. Immunosuppressed patients susceptible to severe disease may be protected from serious disease through the administration of varicella zoster immunoglobulin, that is VZIG. It is prepared through the pooling of plasma from seropositive people. A live attenuated vaccine for varicella zoster virus, that is OKA strain, has been licensed for use in the United States and elsewhere. It is administered after 2 years of age on the same schedule as the measles, mumps, and rubella vaccine. This vaccine induces the production of protective antibody and cell-mediated immunity. A stronger version of this vaccine is available for adults older than 60 years. It boosts antiviral responses to limit the onset of zoster. Dear viewers, thank you for your patient listening. Kindly encourage us by subscribing to our channel. Thank you once again.